Hello, and welcome to the Clinical Care Options Oncology Podcast. I'm your host, Tim Quill. Today's episode features expert answers to clinician questions on NTRK fusion testing and TRK inhibitor therapy for patients with advanced solid tumors. This episode is part of a larger educational program titled Advances in Tumor Agnostic TRK Inhibitor Therapy and NTRK Fusion Testing. During this podcast, Dr. George Demetri from the Dana-Farber Cancer Institute in Boston, Massachusetts, Dr. Alexander Drilon from the Memorial Sloan Kettering Cancer Center in New York, and Dr. Pashtoon Kasi from the Holden Comprehensive Cancer Center in Iowa City, Iowa, will answer audience questions from a series of live CCO webinars on such important topics as appropriate assays for NTRK fusion testing, optimal use of approved TRK inhibitors, including treatment sequencing, and emerging data with next-generation TRK inhibitors. For more information on our expert panel, along with a link to the complete program, including downloadable slide sets, please visit the show notes for this episode. Now let's get started and hear what the experts have to say on this important topic.
What about testing a common cancer with an incidence that's low for TRK fusions like pancreas cancer, but where often you have very little tissue from the diagnostic biopsy? Is that the situation where NGS upfront might make a difference? And that's a very important question. I don't think any of us really know the answer, but I do think it is the situation where many of us would choose to start with NGS. Let me turn to one of my colleagues here, Dr. Kasi. You're a GI oncologist. What do you think about using this upfront for diagnosing, let's say, pancreas cancer, where often you get very little tissue?
That's a great question, and we'll show some data regarding pancreatic or biliary cancers, where often the diagnosis is made on endoscopic ultrasound, or tissue is often obtained through some endoscopic procedure where it's not sufficient for an NGS-based assay. In the new guidelines, at least for NCCN in the US, they now recommend getting tumor-based genetic testing NGS for patients with metastatic or advanced disease because there is increasing incidence of these subtypes which can benefit more from targeted therapies like the breast cancer gene mutation, and in this case, the NTRK fusion, because the survival otherwise is so poor and it's so dramatically better for the ones who have this fusion that we would recommend getting NGS up front. So that way, if there is a problem, you know you have a chance at getting another tissue, either going after a liver met or some other accessible part where you can get some generous biopsies. So yes, I would recommend NGS up front in these settings.
Okay, thank you. Alec, there's a question that I'll toss to you as a thoracic oncologist. If there's an NTRK fusion in a lung carcinoma patient, do these patients tend not to respond to immunotherapy regardless of their PD-1 status? Because we know that the EGF receptor mutant patients, for example, tend not to respond to immunotherapy. Do you want to take that one? It's an excellent
Yeah, absolutely. We're actively looking at that question, so we don't have a lot of data yet to talk to. However, beyond EGFR, we've seen with other fusions like ALK or ROS1 or RET, that when you look at single agent immunotherapy in particular, we see a very low likelihood of response. And that's internal data at Memorial, but also a global registry that we were part of. My guess is that it would be similar for TRK fusions, especially since most of them tend to be highly reliant on just the fusion and aren't really very genomically complex when you look at their molecular reports.
Thank you. And then Maher asks, could liquid biopsies be useful for finding TRK fusions? Now, let me just say, we have some real concerns about whether liquid biopsy is adequately sensitive to find TRK fusions. My bias is that a negative is not non-informative. If you get a liquid biopsy and you do not see a TRK fusion, there's a pretty high chance you could have missed it. So let me not elaborate on that further, but bring that question back at the end.
There's one last question about what do we consider high versus low with some of these actionable findings? And I guess, it used to be that anything that was less than 10% was considered rare, but for some of these new novel efficacious drugs, pembrolizumab, for colorectal cancer is less than 4% for MSI high. NTRK fusion is less than 1% for a lot of tumor types, but The word rare, I don't think we can put a number. And, for those rare patients, when we do find it, it's such a great viable option that, I don't know, Dr. Demetri, Dr. Drilon, do you have a take on what you consider rare as an aberration, especially when it comes to NTRK?
I think certainly 1% is rare, but that's why I think we need at a public health level some sort of a cheap and effective way of screening to figure out who to do NGS on without spending millions of dollars, to be honest with you. Eventually, I'm convinced that the NGS testing will become a commodity and will be much, much, much cheaper. But I think for the next 5 to 10 years, it's still moderately expensive. When CT scans came out, we thought they were going to break the bank back in the 1970s. And clearly, we figured out how to make CT scanning a commodity at our centers. And I do think this will become part and parcel of cancer care in the future. Among patients progressing on first-generation TRK inhibitors, is there any benefit to continuing the first-generation med concurrent with the second-generation med?
Yeah, so I didn't highlight this, but the second-gen drugs actually are really good at targeting the fusion. They were not designed only to target the NTRK mutations that emerge with resistance. So the answer to your question is that they would work even if you had subclonal resistance and a smaller population that had these kinase domain mutations. And as you've seen in the clinical data, as single agent therapy, these drugs can work very well.
How often do you see TRK fusions as a resistance mechanism to any other driver? I haven't seen it once.
So we've seen it in lung cancer. So interestingly, the observation first started in EGFR mutant lung cancers treated with osimertinib, where you've seen a smattering of different fusions, ALK, RET, ROS, and surprisingly TRK that emerge at a low frequency as a bypass mechanism. It happens also in other oncogene-driven cancers that get TKI therapy. And in those situations, you can try to do combination therapy and see what happens. It's a reasonable thing to consider if you've exhausted your standard of care options.
And along the same lines, in GI, there's a paper just published by the group from MD Anderson looking at all the liquid biopsies that were done in patients who got anti-EGFR for colorectal cancer, where they had fusions as mechanisms of resistance. So ALK-ROS and along those lines, NTRK is something that can potentially be seen as well. So for whatever reason, these fusions are also escape mechanisms. And interestingly, they actually were picked up on liquid biopsies, which is not necessarily the best test for it. So as a post-anti-EGFR, we do see it as an acquired mechanism of resistance.
Thank you both. Cynthia asks a question I've heard from other practicing physicians as well. Do you think the time to resistance on a first-generation TRK inhibitor is driven by how much prior therapy the patient has had? In other words, do patients who have had extensive prior chemotherapies have a shorter duration benefit, or does it not matter?
Yep, in our data set, we've looked at that, and it does not seem to matter. Of course, the medians here are very long. With much more mature data, we might see a signal. This is sort of the tracer X hypothesis that if your cancer is more genomically complex after prior therapies, then it's easier for these cancers to develop resistant subclones. But right now, there's no strong data to support that hypothesis.
Yeah, I think that's really important. So even if a patient is heavily pretreated and you find a TRK fusion, it's definitely worth trying. It still could be an incredible benefit to the patients. And there's another question here. I'll have you read this one, Alex, and Dr. Pashtoon, because it may be that both of you had a different approach to this. It revolves around MET amplification.
Mm-hmm. So it sounds like there are a few questions. Why would you recommend standard of care for off-target MET-mediated resistance? And the question that preceded that was, why not go on monotherapy, I assume, with a MET inhibitor and not a TRK inhibitor? Okay, so I'll answer the latter first and say that as with on-target resistance, sometimes the bypass resistance does happen only in a subpopulation of cells. And so you still need to control the other original cells with the TRK fusion in addition to the cells that have bypass resistance. So while you could try monotherapy, my guess is you may see a transient response in those subclones, but very quickly lose it. So I would be worried about doing that over combination therapy. The reason I recommend standard of care is because we have very little data so far, and really not large trials, prospective data to guide our decision making here. In the future, if we have a data set that says, you know, a MET plus TRK inhibitor for MET-dependent cancers results in a really good response rate, disease control is durable, then I'd be more confident recommending targeted therapy at that point.
And just to add to what you said, there is, again, not directly relevant to NTRK fusions, but there is data to suggest that as you develop these acquired mechanisms of resistance, potentially if you do something that's not directly relevant to the pathway, then those acquired mechanisms of resistance, quote unquote, could fade away. So you could then go back to the target therapy again. It's increasingly being recognized in different tumor types. So doing something that would be standard of care would allow for off-target therapy, and then you could potentially go back to either the first or second generation drugs.
Thanks, Dr. Kasi. Does the response to TRK inhibitors change depending on whether the patient gets it as first line, second line, etc.? And let me start with you, Pashtoon. Do you want to address that in, let's say, colorectal cancers?
So most of the data we have is in patients who had prior chemotherapy. So in terms of treatment naive, other than case reports, or like this patient, for example, who never had chemotherapy, I don't think the line of therapy or previous therapies so far has shown anything to limit the responses. So I would say the driver is so robust that the efficacy is preserved regardless of the prior lines of therapy.
Yeah, Alex, how about in lung cancer and other cancers that you've seen?
I agree with that, and I'll extend that observation to other oncogene lung cancers where people have asked the same question and it doesn't matter.
Yeah, that was one of the big surprises even in the early days of Gleevec, that it didn't matter if somebody was treatment naive with what we call GIST or some other name that GIST was given in 1999, all the way through somebody who's had 5 prior chemotherapies failed to control their disease. If you give them Gleevec, boom, it just all goes away. So that's what you just said, Alex. If you've got a really potent driver, like a KIT mutation in GIST or a TRK fusion mutation in any of these cancers you've heard of today, it does tend to work. And it's why we feel so strongly about finding these patients. We want no TRK fusion patient left behind, because that's what's good for patients. And we have to figure out how to do that. I can see Patrick asked a question. RNA allows the identification of a greater number of fusions, but poses challenges in terms of sample stability. It's true. RNA is more fragile and can result in less sensitivity if the tissue hasn't been well preserved, if the tissue sat around too long for a variety of reasons. In many ways, the balance between a DNA test, NGS, or an RNA test has to be looked at by the performance of that test, and it's very hard to assess that. I will say that many of the good high-quality DNA tests have very thorough DNA base sets, but there may still be, because these genes can be big and they can have a lot of area between the kinase domain and where the fusion actually occurs. So it can be a real challenge. Actually, let me invite my other colleagues here and invite somebody else also to comment on this. I don't know, Pashtoon, do you have any thoughts on this about how your institution deals with DNA or RNA testing?
You know, I was going to comment on the same, that at a higher level, it brings the question of cost versus tissue efficiency as well. You know, advances are coming for subsets with not just NTRK fusion, but other actionable targeted therapies that we have now, an increasing number every passing year, not just for non-small cell lung cancer, but we'll talk about colorectal cancer, some of the other cancers too. You know, I'm of the opinion that it probably is a good idea to go upfront broad NGS. So not only just from a cost standpoint, but also if you go the reflex approach of IHC first for one test, or testing for EGFR, and then you'll test for your BRAF after EGFR is negative, and then order your ALK, and then you'll order your NTRK. Every single time pathologist does that is also concerned regarding how much tissue you have left for each assay. My worry is by the time they get to NTRK, some of these patients, for example, your non-small cell lung cancer patient who had a lung CT-guided biopsy, there's not a lot of tissue to do all these tests in a sequential manner.
I think that's true. Alex, you're a lung cancer person as well as early drug development. So what's your thoughts on that?
Yeah, I think that thankfully these assays are getting cheaper over time, and hopefully the turnaround time will go down as well. I think circling back to the RNA question, something that the Boston group has championed has been doing double extractions of the nucleic acid up front. That way you don't do a tiered system where you exhaust the DNA and kind of rely on the lysate for the RNA, and then deal with maybe not having enough tissue at that point beyond the stability questions that were posed. So I think that as these tests get easier to run, and hopefully as we recognize the importance of incorporating RNA, then maybe just extracting the RNA up front and doing both tests in parallel, assuming costs aren't prohibitive and payers will cover the charges, I think that's probably a good strategy to go.
One question that, if I can start with that, and we'll go to the panel, I guess if there's any preference on which commercial NGS platform to use or which has higher sensitivity, and it's a good question. I think my answer to that often is, I think it's important to know what each NGS platform is offering. I think my other colleagues can comment on that as well. There are some platforms that do the RNA, and they will tell you which fusion partners that they're testing the DNA. So it's important to know whichever panel that you're using, whether it's in-house or a commercial NGS panel, that they are providing adequate coverage for NTRK. I don't know if Dr. Demetri, you have any comments or thoughts. I don't think there's any.
No, I wish I had an answer for that. I wish we had 100 samples that went through everybody's test platform so we could actually know something like that, but we don't. So I think people just get comfortable with their test, whether it's an internal academic test or whether it's one of the commercial tests. And I don't know a way out of this other than with experience over time. And Alex, any words of wisdom from you too?
Yeah, I think it's absolutely right. There's no good comparative data that will direct us one way or another. I do think it is important to make sure that when you look at the NGS panel, that you don't just look at the gene list, right? Because some of these are amplicon-based panels that might find NTRK mutations, but you're actually looking for the fusions. So it's important to make sure that you sort that out beforehand.
Kind of goes to the next question in terms of asking, is it the drug that's so amazing, or is it because we found a real driver? And I think it's kind of both, because in many situations where you have an NTRK fusion, they tend to be drivers, and that's why often, like Dr. Demetri was pointing out earlier, if you have BRAF V600E or some other tumors, and even in colorectal cancer, there is some data from MD Anderson group where it seemed like, similar to like what Dr. Demetri was saying, the quad negative, it seems like the NTRK positive are the ones who are KRAS negative, BRAF negative, and lack of other actionable findings. So these negative patients do have this preponderance, which kind of is what would be a definition of a driver, where they often are not present together. Alex, Dr. Demetri, thoughts on that as a driver?
I think you're right, and I think it's both. I think we've got great drugs against a great target, which is exactly what precision cancer medicine should be all about.
I do think it's also both. I'll note that there are other inhibitors that are less powerful against TRK. Crizotinib is a well-known drug and has minor TRK activity. We've seen some disease regression in 1 or 2 case reports, but really I don't think that a drug like that would achieve the outcomes that you've just shown us in your presentation.
Right, and Pashtoon, one of the key questions, I'd like you to address one of the questions that came through, which is, Sandra says, in your patient who started MSI-high colon cancer with IO therapy, in retrospect, how do you make the decision about whether to do IO first, or whether you maybe even would have done better by starting with larotrectinib and save the IO? So what's the answer to Sandra's question? Good question.
Well, it's a good question. I don't think we know the answer. However, I would say that there is increasing amount of data for first-line IO. The plenary at ASCO was actually first-line pembrolizumab versus chemotherapy and achieved the primary objective. And within a couple of weeks, FDA now has approved single-agent pembrolizumab first-line in chemo-naive patients. Previously, you had to fail chemotherapy, or in the NCCN guidelines, they did make a note that if you think that somebody would not tolerate chemotherapy, or in this case, does not want chemotherapy, then you could make a case of giving IO. And then last year at ESMO, there was data on Ipi-Nivo, first line in chemo-naive. So from a clinical practice standpoint, again, IO is also, immunotherapy is also one thing, at least for MSI high. I wouldn't be wrong in saying that MSI high as well, when immunotherapy works, it's nothing less than dramatic, to the point that at least for MSI high colon, we often are comfortable, and I've seen experts use the word, curative, which is pleasantly surprising, because a lot of these patients, there's a flat plateau, they come off of therapy and are, disease-free years out, and some of them who actually ended up getting surgery, we see the same as we saw in this case, that they have a complete patch response, that the surgeon didn't find any cancer at all. So I think as of right now, if I were to choose, I would still probably choose an IO-based therapy, because you have the most data, and actually it's a part of guidelines, and also I would ideally enroll in a trial if that was available. And there are some first-line immunotherapy trials, so that would be my first priority. But if it doesn't work, then NTRK fusion inhibitor would be an option, and that's how the current approval is not in naive patients, it's after failure of whatever standard therapy. So my answer would be IO first and NTRK inhibitor later.
Okay. What I'm going to do is pose to my panel members a number of the key questions and ask for a response in 15 seconds or less. So it's concise. Alex, in off-target resistance, should you combine the TRK fusion inhibitor along with the treatment targeting a new mutation? What do you think? Go.
My rapid fire answer is yes, because if it's a subpopulation, there are still TRK sensitive clones that you need to hit. So best to try to give two drugs together.
I think that's really interesting. I think the issue might be safety, but be careful out there, folks, but that's where the future is headed. It's in combinations. Okay, what about Pashtoon, patients with NTRK fusion who have a KRAS mutation or a BRAF mutation? What would you recommend?
So the answer is an NTRK fusion likely would not have the other mutations present. So that's why it's in the quad negative or bi-negative patients. So that scenario would be more theoretical, and I would still choose the fusion as the driver.
Yeah, sounds good to me. As we get into resistance, I wonder if RAS mutations are going to be a resistance mechanism for TRK fusion, but hopefully we'll not have to deal with that for a long time. A comment from a colleague, Israel, who says it's his understanding that TRK fusion inhibitor drug use is not approved as a first-line therapy. I don't know, Alex, do you want to comment on that? That is actually my understanding, but I have seen a lot of first-line use.
Yeah, so I think that many practitioners have taken a page from lung cancer, where we've definitely looked at randomizing oncogene-driven tumors to chemotherapy or standard of care versus a TKI. And we see that the TKI strategy is superior. So at least at our center, we've started with first-line therapy. I certainly would. I think that the clinical outcomes that you're seeing here, especially with the updated data for some of the drugs, where you see progression-free survival or duration of response exceed 3 years. I'm not sure we see medians like that with some of our standard therapies.
Thanks, Alex. I'm going to take this one. Should CNS tumors be tested from the very first biopsy? You know, I'm not a neuro-oncologist, but I would have to say absolutely. CNS tumors, primary CNS tumors like glioblastomas, are such a horrific disease that if you have a highly active driver, it's not going to be common, but boy, if you have it, you know, you're cursed to have the disease, but you're blessed to have something that hopefully this drug could do something, one of these drugs could do something about. So I would have to say, we'll leave that to the neuro-oncologist, but I would say that's a very reasonable thing to test CNS tumors right from the first biopsy, primary CNS tumors, let me add.
I agree. And just a quick sidebar, George, we've seen responses in CNS tumors too. So definitely test.
Yeah, no, definitely with both drugs, with larotrectinib and entrectinib, there have definitely been responses in kids as well as adults. I think that's important. Okay, this is a little bit of a technical one, but I wanted to bring it up. What Jan asks, what can you recommend if a DNA NGS test cannot confirm if a TRK fusion is in frame or out of frame? Alex, how would you answer that? I have my way, but I do think some of these NGS test reports are a little confusing.
Yeah, I think one clue there is often the way it's reported is a little equivocal. They'll say, oh, we're seeing a rearrangement or a deletion. I think it produces a fusion, but we can't say for sure. This is a variant of uncertain significance. What I typically do is I pick up the phone and I call my pathologist, or I even send an email to the company and say, can you clarify?
Yeah, I think that's a really good advice. We've had that happen a few times. And frankly, if they've done it on DNA, we insist that they then do it on RNA. And at that point, if it's negative in the RNA, it's just a rearrangement, and it really wouldn't have been good to start with one of these TRK fusion drugs. I want to thank my expert panelists here. It's been a pleasure working with both of you, and it's always a privilege to talk about safe and effective new drugs that are this safe and this effective. And again, I don't say that about a lot of drugs, but I've been lucky in my career, and Alex is very lucky in his career, and Dr. Kasi is lucky in his career, because we do happen to have several of them here in the form of the TRK fusion inhibitors. I'd like to thank everybody for joining us today.
Thank you very much, Dr. Demetri, Dr. Drilon, and Dr. Kasi, and thanks to you, the listeners, for joining us. As a reminder, to view the full program, Advances in Tumor-Agnostic TRK Inhibitor Therapy and NTRK Fusion Testing, and to download the slide set associated with this discussion from the Clinical Care Options website, please click on the link in the show notes. As always, thanks for listening.